This video is set to be featured in the Cadaver Workshop at the ESRA Congress, which will take place in Prague in September 2024. The workshop aims to provide an immersive educational experience, and the video will serve as a key component of the learning material. Attendees can look forward to a comprehensive visual guide that complements the hands-on training sessions. The cervical plexus is a network of nerves that emerge from the cervical region of the spinal cord, C1 to C4. It is divided into two main parts, the superficial cervical plexus and the deep cervical plexus. The deep cervical plexus is located deep beneath the prevertebral fascia, and it is formed by the anterior branches of the upper 3 or 4 cervical nerves. It gives rise to motor branches that innervate the muscles of the neck. The superficial cervical plexus is primarily formed by the anterior branches of the upper 4 cervical nerves and gives rise to cutaneous nerves that supply sensory innervation to the skin of the neck and the posterior part of the head. Lesser occipital nerve, the great auricular nerve, the transverse cervical nerve, and the 3 branches of supraclavicular nerves. The brachial plexus is a complex network of nerves that originates from the spinal nerves of the cervical and thoracic regions, C5 to T1. It is responsible for the innervation of the upper limb, including the shoulder, arm, and hand. The brachial plexus is formed by the merging and branching of these spinal nerves, giving rise to several major nerves that control the motor and sensory functions of the upper limb. The supraclavicular nerve is a sensory nerve of the cervical plexus that arises from the 3rd and 4th cervical spinal nerves. It emerges from beneath the posterior border of the sternocleidomastoid muscle and then splits into multiple branches. Together, these innervate the skin over the shoulder. For scanning, the transducer will look for the exit of C4. At the moment, it is inserted under the sternocleidomastoid muscle. As the probe moves caudally, the nerve moves laterally to become superficial. As seen before, the brachial plexus is formed by the anterior rami divisions of cervical spinal nerves C5, C6, C7, and C8, and the first thoracic spinal nerve T1. 3 anatomical points are key from an anesthetic point of view: the cervical foramina, the clavicle, and the axillary fossa. The upper extremity is innervated by the C5 to T1 anterior rami, often called the roots of the brachial plexus, which has 3 trunks, 6 divisions, 3 cords, and 5 major peripheral nerves. The C5 and C6 anterior rami constitute the superior trunk, C8 and T1 anterior rami constitute the inferior trunk, and C7 solely forms the middle trunk. All 3 trunks give off an anterior and a posterior division. The 3 posterior divisions merge to form the posterior cord. Meanwhile, the anterior divisions of the superior and middle trunks give rise to the lateral cord, and the anterior division of the inferior trunk forms the medial cord. The lateral, medial, and posterior cords are named based on their reciprocal position to the axillary artery. The posterior cord gives off the radial and axillary nerves. The lateral cord gives off the musculocutaneous nerve, and the medial cord gives off the ulnar nerve. The median nerve is composed of both lateral and medial cords. Those procedures performed above the clavicle will act on roots, trunks, or divisions. This requires a thorough knowledge of the metameric innervation of the brachial plexus. When anesthetic is injected below the clavicle, it is given at the level of the cords, medial, posterior, and lateral cords. From this level, the metameric innervation loses interest, and we must know the specific innervation of each peripheral nerve. If the anesthetic is administered at the axilla or more distally, we block specific peripheral nerves. The brachial plexus in the supraclavicular region is composed mainly of 3 trunks, superior, middle, and inferior. These trunks pass across the upper surface of the first rib, where they lie posterior and superior to the subclavian artery. The trunks then divide into anterior and posterior divisions behind the clavicle. For optimal visualization of the brachial plexus, it is advisable to commence scanning at the supraclavicular fossa. This approach significantly improves the likelihood of accurately identifying the brachial plexus, which can be likened to a cluster of grapes located behind the subclavian artery. Initiating the scan from this vantage point allows for a clearer view of the nerve bundle, facilitating a more precise assessment. The patient may be positioned in the semi-sitting position achieved by raising the head of the bed to a 45-degree angle, or the supine position with the patient's head turned away from the side to be anesthetized. Typically, the ultrasound probe is placed in a coronal oblique orientation just posterior to the clavicle's midpoint to visualize the short axis view. To accurately locate the subclavian artery and brachial plexus, the supraclavicular fossa is scanned in the short axis view. It is also essential to identify the first rib and the cervical pleura within this view for a comprehensive assessment. The ventral rami of spinal nerves, C5 through T1, commonly known as the roots of the brachial plexus, converge to facilitate the intermingling of their fibers, thereby forming the superior, middle, and inferior trunks. Identifying these roots or trunks using ultrasound can present challenges in certain patients due to anatomical variability. However, the trace-back method enhances the ease of location by guiding the transducer cephalad, ensuring continuous visualization of the plexus until reaching the interscalene groove. The interscalene block, a procedure utilized for surgeries involving the proximal arm, shoulder, and clavicle, involves the administration of a local anesthetic around the upper trunk, composed of C5 and C6, as well as the middle trunk, which includes C7. The brachial plexus is visible as small dark spots in the interscalene groove due to the high concentration of nerve tissue in this area. These nodules are located between the anterior and middle scalene muscles beneath the prevertebral fascia. To identify the roots, we recommend using the traceback method. This involves sliding the transducer upwards while maintaining visual contact with the plexus up to the interscalene groove. The differentiation of cervical levels by ultrasound relies on the distinct anatomical features of the C6 and C7 transverse processes. Specifically, the C7 transverse process is distinguished by its small or absent anterior tubercle on ultrasound. This feature allows comparison with C6 by moving the transducer over the adjacent vertebrae. The posterior divisions of all three trunks unite to form the posterior cord. The anterior divisions of the superior and middle trunks join to form the lateral cord, and the anterior division of the inferior trunk forms the medial cord. These cords are named according to their relationship to the second part of the axillary artery. The neurovascular elements are enclosed within the anatomically variable, multipartitioned axillary sheath, a fascial extension of the prevertebral layer of the cervical fascia covering the scalene muscles. The costoclavicular space, which is the initial segment of the infraclavicular space, is situated beneath the clavicle and above the second rib. Within this space, the brachial plexus is tightly arranged at this level, positioned laterally to the artery and at a more superficial depth compared to the conventional approach, potentially offering a more advantageous site for achieving nerve block with a single needle insertion. For optimal ultrasound imaging, position the patient supine and abduct the arm at the shoulder, ensuring the head is turned away to a slight degree. Situate the transducer just below and in alignment with the clavicle, along the midclavicular line. Then angle the transducer marginally caudally to orient the ultrasound beam's trajectory cranially, allowing it to pass beneath the clavicle effectively. The brachial plexus can be identified as a group of nerve structures, triangular and located lateral to the axillary artery. The main peripheral nerves that emerge from the brachial plexus are the musculocutaneous, median, ulnar, radial, and circumflex or axillary nerves. Each nerve has a distinct pathway and innervation area, necessitating precise techniques for effective blocking at the desired level. For an axillary approach to the brachial plexus, the humeral artery can be visualized as the center of a four-quadrant neurovascular bundle. It is important to note that anatomical variations exist, but the most common anatomy relative to the axillary artery is as follows. The median nerve is found in the superficial lateral quadrant. The ulnar nerve is in the superficial medial quadrant. The radial nerve is in the deep medial quadrant. And the musculocutaneous nerve is in the deep lateral quadrant in the substance of the coracobrachialis muscle. The patient ideally should be placed in the supine position, with the arm abducted 90 degrees and externally rotated so the dorsum of the hand rests on the bed. Preferably, the operator should be positioned behind the patient with the ultrasound machine in front of the patient and facing the operator. The ultrasound probe is placed transversely on the proximal medial upper aspect of the arm, with the leading edge facing laterally to view the axillary artery and surrounding nerves in a short axis view. At the level of the mid-forearm, the median nerve is found as a hyperechoic structure embedded in the hypoechoic flexor digitorum superficialis and flexor digitorum profundus before it enters the carpal tunnel, where it can be confused with the tendons of the flexor muscles. The nerve should be confirmed by fanning the probe along its course. At this point, the nerve has the characteristic honeycomb appearance. We suggest a mid-forearm approach to the ulnar nerve because the nerve is easily found at the ulnar artery landmark. As well, the nerve starts to separate, and the risk of arterial puncture may be avoided at a somewhat proximal location. Nerve appears as a triangular hyperechoic structure medial to the ulnar artery. Hyperechoic ulnar bone shadow is also seen posteriorly. It is recommended that the radial nerve be blocked at the level of the upper arm, which theoretically provides greater coverage. This technique involves placing the probe transversely, approximately between the upper and middle third of the arm, over the triceps muscle as it crosses the humeral shaft. The radial nerve wraps around the humerus within the spiral groove before dividing anteriorly into its superficial or cutaneous and deep or interosseous branches. Thank you very much for your attention.